Welcome back to the Lipoedema podcast. We're your host, Shell.
And tonight we are joined by special guest and plastic surgeon, Dr. Naveen Somia. Dr. Somia, thank you so much for joining us. We've been very eager to chat to you.
Thank you, Shell, and thank you, Tiana, and thank you for having me on the podcast, and it's my pleasure to be here.
It's such a pleasure to have you. I'm going to dive right in because we tend to, that half an hour goes so quickly. So let's get straight to it. Shell and I would love to know how you came to learn of lipoedema and when was that?
It's a very interesting story because I had a patient of mine who came and saw me, and one of the first questions she asked is, do you do liposuction? And I said, yes, I do liposuction. And she asked me, do you do liposuction for lipoedema? And I said, look, I'm embarrassed to say I don't know about it. So then, and she said, you're not the first one. And she said, I'll give you some papers to read if you're interested. And then that's what I did. So I did some research and I said, look, it was quite prevalent based on the scientific research I did. And what was quite evident was it's the staggering incidence of lipedema across the globe. And I said, this is so bizarre that I've been a specialist plastic surgeon for a few years and I haven't even heard of this. And despite the scale of the problem and the incidence across the world. So when I did more research about this condition of lipedema, it was very evident that it is a distinct entity compared to lymphedema that all of us are very familiar with, and it's a well-known entity. And what was surprising was all the research papers that came out of Germany. So I said, this is a bit odd because they talk about a global prevalence and global incidence across all countries, but bulk of the research and publications come from Germany. So that's what made me wonder as to why is it so special. So that's kind of when I delved deeper. Then I came across a surgeon in Germany called Joseph Stutz, who written a few papers. Then I contacted him and said, look, is it possible for me to come and visit you and learn a little bit more about how you manage patients and understanding the difference between liposuction for non-lipedema patients and liposuction for lipedema patients? And that's how the journey started. So then we started doing a few patients with liposuction. What was very evident was the surgeons in Germany had established a standard protocol, and the technique that they used as a benchmark was body jet or water-assisted liposuction. So there was a reason, scientific rationale behind it, and a published paper supporting the scientific efficacy of water-assisted liposuction in being very gentle on the lymphatics or lymph-sparing liposuction, but targeting the fat. And since body jet or water-assisted liposuction was a part of the German technology, it made more sense when you put 2 + 2 together. So there was no reason to change it because it's a well-established standard in the industry. So that's how it started, and slowly the practice grew from there. And this was about 11 years ago. And since then, it's been very studied. It's been a self-directed learning, and went and visited a few surgeons. And of course, you read a lot about lipedema, and then you do your own research and find out, okay, fine, this is something that is so complex that the mystery keeps unraveling every day.
That's astonishing that your introduction into lipedema was actually led by one of your patients. And it's so heartwarming to know that we have clinicians like you out there that listen to us, not only listen to us, but then extend on that and do your own research and contact these specialists and go and visit them in Germany. Like, thank you from the community for actually listening to us as patients, because sometimes, especially with this particular condition, it's often misdiagnosed as obesity, and we get dismissals, I suppose. And so it's nice to actually talk to somebody in the community that really took what we were saying on board and believed us. So that's an amazing introduction 11 years ago. So now you've got quite a bit of experience and have done quite a number of lipedema extraction surgeries yourself. So you continue with the water-assisted liposuction. Is that correct, Dr. Somia?
That is correct. I use water-assisted liposuction, or WAL. Yep.
Fantastic. And can I ask, I've got a curious question about the difference between lipedema extraction surgery, lipedema liposuction, and normal cosmetic liposuction. Would you know the differing techniques used?
Look, I think it's can I just get back to lipedema extraction? This kind of incorrect terminology, because when you talk about lipedema extraction, you're talking about extracting lipedema. You're extracting, you're removing fat. So I think APRA is a medical regulator. They're very strict on terms that could be seen as inaccurate or misleading. So we want to, since we are talking about what is a regulated health service, we need to be very clear about what we say. So for that reason, we will say we'll stick to the fact of liposuction, which is a technical term for removing a fat. Okay, because lipedema extraction implies that you're extracting lipedema, like the genie out of a bottle. Right?
Fascinating.
So,
Okay.
So lipedema, liposuction, the target is the abnormal fat cells, which is excessive and located in certain areas. Liposuction for non-lipedema, the target is excessive fat cells that are normal, right? So that's the difference. So the indications are patient-led indications. A patient is not happy with the extra amount of fat due to contour issues or unable to get rid of that little fat, or in lipedema patients, it is predominantly symptomatic. In other words, painful, not responding, growing, and causes a whole heap of physical symptoms as a secondary issue. So in terms of trying to do liposuction, the technique, the protocols are all very, very similar, because I use water-assisted liposuction for cosmetic liposuction as well as for lipedema liposuction, right? The technique is identical. You don't vary the technique, because technique is about making sure the integrity of the tissues is protected, not harmed, and the safety of the patient is not compromised. Right. So the protocol that you do in terms of the anesthetic safety, the preoperative optimization, the intraoperative optimization, the postoperative care, all have to be well and truly to the highest possible standards. Either way, the indication does not make a difference to the standard. They have to be identical and very high. The only difference in lipedema is because the target is to remove as much of the abnormal fat as the disease fat causing pain, we tend to be a bit more aggressive, because the benefit to the patient is in debulking the fat. And obviously, there is a significantly higher amount of fat per limb. So it is not uncommon for me to take out a lot of fat in lipedema patients as opposed to a cosmetic liposuction. So the only difference that varies is the amount of fat you take, and the endpoint gets defined early on, because the cosmetic liposuction is done for a very specific endpoint. And that will not be something similar to an endpoint of what a lipedema patient requires from a lipedema medical management perspective.
Fascinating. Okay, I'm taking that all in, and it's taking me a minute, I must admit, to know that there's limited key differences between a cosmetic liposuction and lipedema liposuction. So thank you, because I think our community really questions that as well. We have lipedema specialists that come from various specialties, not plastic surgery, and we always was curious about any key differences between the cosmetic and the lipedema. So thank you for clearing that up for me. That's really curious.
Yeah, the technique, there's a technique that has to be absolutely meticulous. It's the patient management has to be above board. You have to have optimization at every single, it's mainly a risk mitigation thing. Yes, the lipedema patients have a slightly different risk profile compared to non-lipedema patients, but it's the principles of safe surgery are the same, whether you perform surgery for cosmetic purposes or surgery for non-cosmetic purposes. It's the same.
And how do you know, Dr. Somia, whether you're taking out normal fat tissue or lipedema tissue?
There is no way of knowing what you're taking out, because both normal fat and lipedema fat look identical to the naked eye on the operating table. Okay, so there's no way of knowing it, right? But we can say categorically that if you look at the clinical behavior of lipedema, say, for example, the thigh fat, fat in the thigh deposited between your hip and your knee, as opposed to fat in the leg between your knee and your ankle. The thigh fat, I tell patients that it's quote unquote 50-50. There's 50% of normal fat and 50% of lipedema fat. And what is a proof to prove that? Say if you lose a massive amount of weight, whatever method you choose, your thighs will go down in size. You may be left with loose skin, but your legs, knee to ankle, will not change. And I've seen plenty of my patients who have gone and lost weight, right? 30 kilos, 40 kilos, 50 kilos, 60 kilos. Thighs have come down in size, but the legs have not changed. So when you go into the legs, which is the knee to the ankle, and extract fat through water-assisted liposuction methods, you can be pretty certain what you're taking out is lipedema fat, because normal fat does not happen there. Because had it been normal fat, what we know about normal fat in its response to diet and exercise, it'll go down. And because they are resistant to that response, you can expect that by default, what is left over has to be lipedema fat. And I always find that the more the fat you take out from the leg, it has a slightly paler color, like it's more whitish than yellowish. And that's what I've observed. And that could be due to the fact that you have a large amount of stasis of fluid in the leg. So if you palpate or touch the leg and touch the thigh, one is a bit more softer, one is a bit more harder, implying that there's been stagnation of lymphatic fluid for quite some time. So there must be some sort of process that happens as a part of that stagnation that make this fat a bit more paler and whitish compared to yellow fat of the thigh. That's the only difference you can see.
That's so interesting. I didn't know that. So if you're saying that the mechanisms of, standard liposuction and lipedema liposuction are similar, in the community, I know we get a lot of feedback about going to a lipedema specific specialist to get our lipedema removed or managed. What say you, and you might be the wrong person to ask because you are a specialist in lipedema, about going to a standard cosmetic surgeon for your liposuction if you do have lipedema?
Okay, a couple of things. I think the current APRA guidelines and the laws of the Medical Board of Australia have specifically said that you cannot call yourself a surgeon unless you're a registered specialist surgeon. Okay, so if you are a registered specialist surgeon, whether you're a plastic surgeon, general surgeon, otolaryngologist, cardiac surgeon, only then you can use the title surgeon, right? So if you're a non-registered specialist surgeon, you cannot. I think obstetrics and gynecology, they can use the word gynecological surgeon, and oromaxillofacial doctors can use the term surgeon as well. But so the term cosmetic surgeon is no longer permissible by people who are not specialist surgeons. So if I call myself a cosmetic surgeon, it is not okay, but okay, if you know what I mean. Yeah. I wouldn't use it personally. I would rather use specialist plastic surgeons specializing in cosmetic surgery, right? So now, to call yourself a specialist, there's certain strict statutory criteria as to who can call yourself a specialist, because APRA has decided that the title specialist is quite misleading if it is not a legitimate specialist. So there are very specific categories of specialist qualifications in Australia, and unless you are one of the registered specialists with specialist registration in that specific discipline, you need to be careful of using the term specialist. So I can call myself a specialist plastic surgeon because I'm registered in the specialty of plastic surgery. But if you're not registered in a specialty, then you need to ask yourself the reason for calling yourself a specialist.
Gotcha.
Make sense? Yeah.
Yes, absolutely. Yeah. And those guidelines really are protecting us, aren't they?
Yeah, the guidelines are designed to protect patients after years and years of historical abuse of the title and years of poor patient outcomes and poor professional standards that are quite evident on social media and television.
Very good. Thank you. Dr. Somia, in your practice and focusing on lipedema, your lipedema patients, how do you determine your patient to be quote unquote surgery ready?
Okay, so the simple argument is, if you take, this is what we tell at the consultation, right? If you go back 40 years, surgery was not even an option. Surgery was actually frowned upon, right? Because it was assumed that the surgery is going to cause lymphatic damage and make a lipedema a lymphedema, right? Almost permanent, irreversible condition. So what has changed is the technology has changed, and some science has helped to improve the understanding of how you can safely perform liposuction without damaging the lymphatic system, right? So the standard benchmark for treatment has always been the conservative treatment of making sure that you decongestive therapy of compression, the pumping, the exercise, the MLT, and all those things that get done. And I say that that is the cake. Surgery is the icing on the cake. Surgery can never replace the cake. In other words, the success of surgery can only be maintained by constant, regular, non-surgical maintenance for life. So you may choose to have surgery, but if you choose not to have conservative treatment, then you'll not do as well as, say, doing both. So when you're ready for surgery is when you've optimized all your key conservative managements. In other words, your compression is up to scratch. You've lost the appropriate amount of weight. You've got the mobility sorted out. You've got good muscle tone, because your legs do get heavier after your operation, and you need strong muscles to mobilize, because mobility after the operation is the key that helps you to get the swelling down. And I say that the only two things you have to do after the operation of the surgery is to move and pump being the LX9 pump to use, and move is to keep moving every hour on the hour, 10 minutes. That's the muscle that keeps going, because otherwise the fluid will pool. And together with compression, the LX9 pumping or the lymphopress pumping, and then your moving mechanically, these are the three things that will help the swelling resolve quicker and faster. So if you haven't optimized them before, there is no way you'll be able to do that after, because it's quite an uncomfortable situation post-op. You feel like you're boxed in, tied up, and feel like a prisoner in your on compression garments. And every single patient who has gone through this process says that it's always worse off than what they thought it was going to be.
Yeah, here,
Yeah,
Dr. Somia. I have been through 2 surgeries, and
yeah,
it was rough. It was really rough.
yeah,
It's not an easy way out.
yeah.
But I'm so grateful that I had the opportunity to do it. But yeah, it's tough going.
Yeah, it is. It is. And I think it's, you can't be more prepared. You can't be perfectly prepared. So the more you think about this, take time to digest it, because even if you work out your compression, it takes about a good 3 to 4 months to understand, like, okay, fine, this is what is right for me in working. Any kind of exercise regime takes a long time to, recalibrate and recoup and see some positive benefits, because you're doing all these things. And so that's why we said it's take your time to get ready. And once people say that, yep, I've done all the positive things, I've seen the changes, then yes, they're ready. The other thing that we tend to focus on a lot is the concept of metabolic health, because it's a very grossly ignored uh, component of lipedema, because when lipedema and obesity or adiposity coexist, and especially if you're in the perimenopausal stage, it has a different effect. We can't predict what kind of effect it is, but it has a much more amplified effect. And the metabolic health parameters in a general population, 30% of people who are of a normal weight have suboptimal metabolic health. And that percentage increases as soon as you cross into the overweight category, the obesity 1, 2, 3, and morbid obesity category. So, and if you're going into the perimenopausal time, that things become a bit more difficult. So you want to optimize all of those before you go through surgery, because the stress response post-surgery may trigger off something else. You have no idea what's going to happen. So you just need to be kind of very perfectly prepared and optimized beforehand to get the maximum out of surgery. We are very mindful of the fact that going through surgery, because a lot of it is not funded by any kind of external agency, and patients are self-funding, we're very mindful of that fact that it's not a insignificant commitment, right? So we want to make sure that everyone gets the best out of it. And sometimes we may come across as making sure that you're make sure that you have the strict protocol, but we don't want it to be taken lightly that it's an expendable option. It is a very, very risky option for the patient because you're going through an invasive surgery for such a long time. It's downtime, and it's not a pleasant downtime, right? It's not like a holiday for 6 weeks, right? It's certainly not. And it's just as painful as it could be. So be very mindful of the fact.
Yeah, nice. And I think it just really solidifies to our community how important conservative management is as a habit, as something that you sustain in your life, because lipedema, liposuction can get rid of the tissue, but it doesn't get rid of the disease.
Problem.
Yeah. Great. Thank you for, as a surgeon, it's really important for us to hear that, because we talk about, you're not ready yet for surgery, and it's really nice to understand what that means. That means that we need to get into those really good habits to manage our lipedema, because the disease is with us forever, even if we're going to get some of it removed.
Absolutely. The tendency to deposit more lipedema fat is a tendency that you've inherited that doesn't change. That gets amplified by the four hormonal surges that you experience in your life: puberty, pregnancy, menopause, and postmenopausal hormone changes. And then 2 lifestyle changes of increased adiposity or obesity and decreased mobility. So they're all interlinked. So if you can only control 2 of those, 6, which is control your weight and increase your mobility. So the more active you are, the better you are, the lighter you are, the better the outcome is going to be, because those hormonal surges that come like clockwork, and you have no choice. So you're better prepared if you're optimized every other angle and go through these hormonal surges. So surgery is also the same. So if you optimize before going through surgery, then your outcomes are going to be far more sustainable. And we'd rather do 1 less surgery for you than 1 extra surgery.
Well, especially with the finances. Here, I say. Also, I just think after we finish this podcast, I might have to go for a walk, because it's been a little while since I've done some exercise. So I better do something. All right, Dr. Somia, let's move on. So just please tell our audience what your patients should expect from their care journey with you.
Okay, so patients get seen by me for a consultation, which usually lasts for about 60 minutes. There's an extensive questionnaire to fill out that very clearly extracts all information about your current status, your management, your history, your what has been done, what has failed. So an extremely detailed history, and also an understanding of what do you know about lipedema, what your expectations are, and also the certain amounts of limitations of what lipedema treatment can achieve. And then we start off with a standard explanation of the pathology of the lipedema and the disease process. As a part of the consultation, we go through why this happens, what are the key things, and it's all about the why. It's to say, why should you lose weight? Why should you do lymphatic massage? Why should you wear compression? Why should you consider walking underwater in a swimming pool for an hour a day? And why is it very critical for you to walk underwater for about 4 to 6 weeks before your surgery? And all those very practical terms. And once you can convey that the why of the problem, the solution, then things become very logical. You'll begin to understand the whole thing in a much better way. So we then give patients we take some photographs of the patients, and we kind of go through examination and say, these are the things that we can target. And because of, I can only estimate how much liposuction is necessary based on the volume I estimate. There's no hard and fast way of saying if I see X by X, it equals 1 liposuction, because the rate of fat removal during liposuction can vary from patient to patient. That is why conservative management to quote unquote soften the fat is a must and a mandatory thing. And I say to patients that if you commit to compression, the pumping, and especially walking underwater, your fat will feel a lot softer. It'll come out much more easily. And I have no kind of reports to measure it accurately, but I've seen anecdotally that I end up taking 10% to 15% more fat if patients have done the work. makes it a lot more easier to extract. And you wonder, oh, why am I taking out so much fat today? Because then you ask the patient, yeah, there you go. They've done a lot of prep work. So these are all practical tips which we've discovered the hard way, and this is what we share. And then patients get given a structured list of things to do and why should they do that, and then they then get the decision to opt in for surgery, which they do independently via a booking form and say, look, I would like to consider surgery, and then we see them once more. There's usually mandatory 2 consultations. One could be a Zoom consult, and one has to be in person. And only after that is we confirm a date and a time for surgery and take it from there.
Are they so good? Do you know, I've been walking underwater for the last 2 months, but I only do half an hour a day. And now you make me think that I need to put in a little bit more effort, Dr. Somia.
Yeah. You just have to subscribe to a podcast that has an hour of podcasting. Because if you have a half an hour, get
water.
Yeah, keeping the water a bit longer. And a lot of the headphones now have got water resistant headphones, so it makes it all the more user friendly.
Oh, okay. I have to invest in a pair of those. So, what are your recommendations for a successful recovery?
It's optimization of the patient at all levels. You have to be mentally prepared to go through it. You have to be physically prepared to go through it. You have to be logistically supported to go through it. And you have to make some adjustments, sometimes minor, sometimes not so minor, in your home or the place where you go back to, right? Now, these are kind of the broad principles of how you optimize and manage. And of course, we take care of all the medical things that are necessary to be managed. And we have an open line of communication. You can call us as a number of times as want. We kind of coordinate the care because a lot of patients, as you know, don't live very close to my practice. Some of them live far away in New South Wales, and some come from interstate. So we're very happy to coordinate care through other methods of communication, along with the coordination of a local healthcare provider, and do this. So, but I think preparing for surgery is the key. You just have to consider preparing your body, mind, and optimizing your medical conditions. So from key practical points is softening the fat is important, has a material impact on how much fat I can take out. So methods are pumping LX9, compression, as well as the walking underwater. Good nutrition, good diet, optimizing all your blood workup is very important for me. And Lipoedema patients have a higher tendency to bruise because of various reasons, which makes you prone to bleed a lot more during liposuction surgery compared to non-lipedema patients. When the scale of liposuction is quite significant and the duration is quite significant, you're talking about, if you do both your thighs, if you think in terms of body surface area, it's quite a large 18 to 20% body surface area of controlled trauma. That is what liposuction is. You're risk damaging blood vessels because there are more blood vessels, friable blood vessels. You run the risk of bleeding very, very heavily. So your hemoglobin buffers have to be good. And we investigate you thoroughly for any kind of bleeding disorders. And occasionally we pick up 1 or 2, which may make the big difference between a good result and a not so good result. And if that's the case, we mandate that you go and see a hematologist to have optimization. And every now and then we have to give patients products like products to help with the clotting during the surgery, or products to prevent the bleeding. Sometimes you have to use medications to soon after surgery to make sure that you don't bleed excessively. So there's a whole heap of hematological protocols that we do, which everyone gets screened for that, and make sure that there's no major issues that can jeopardize. And especially when you have patients who are Jehovah's Witness, and where you cannot have blood products or blood products transfusion, you have to be extra careful to make sure that nothing goes wrong. Okay, so I think this is kind of because you've got zero margin for error there, and just like every other patient. But I think the stress level for the surgeon when you're dealing with the patient is actually slightly more higher. So we kind of tick the boxes twice, so to speak.
Yeah, I guess that's something I hadn't taken into consideration, that like cultural differences and different beliefs, and that you have to consider all of those things.
Yes.
That becomes adds another complexity to what you're already facing.
That's correct. And I think these things do impact patient safety and patient well-being, and which we never compromise, because that is the fundamental principle of surgery. The high standards to deliver good patient outcomes is the fundamental premise of good safe surgical journey and outcome.
Yeah. Yeah. Awesome. Thank you. And I just wanted to go back because we say lipedema extraction surgery, and I love that you addressed that with the APRA term being used properly. And I think it has a lot to do with when you say liposuction, it means someone's getting fat removed, like fat that they've accumulated. And I think for us being in this community, we're not in control of that fat as much. So putting the term lipedema extraction surgery on it for us differentiated for us that it wasn't just liposuction. But yeah, I guess that's something we need to caress a little bit.
Yeah, look, I think APRA is very clear on that. No colloquial terms to be used. It's very simple, black and white, right? So, for example, if I use the word facelift, it is a colloquial term. I cannot use the term facelift in isolation. I have to use myeloplasty or retidectomy along with it,
Yeah. I
right?
remember someone saying you can't say mummy makeover anymore. Like you've got to say
Mummy makeover.
exactly what it is.
Now, mummy makeover is a complex term that is made up of multiple components. As a term, mummy makeover is banned. So you cannot use mummy makeover. So, for example, if you use the term tummy tuck, which is the colloquial term for abdominoplasty, you cannot use it in isolation. You have to use abdominoplasty in brackets tummy tuck or slash tummy tuck. So implying that the medical term, the scientific term, has to go in with the colloquial term. So things like eye lift, you have to mention blepharoplasty, facelift, everything. And July 1 last year, everything changed.
And that's so good because it just cleans up the whole environment for everybody, doesn't it? It makes everybody safer. Everybody knows what's expected. So it's good for everybody.
It's
So,
no
Dr.
different.
Somia, where
Sorry, I was just about to say it's no different to the accuracy of labeling in a food product in your supermarket.
yeah. Yep, absolutely. So, where can the lipedema community find you?
Lipedema community can find me through my website address, and also in that contact details of the website will also be my room's way to contact us. So it's very straightforward. It's naveensomia.com.au. And there's usually a tab on lipedema, and you can connect us through that.
I saw you have your own podcast. Would you like to give that a bit of a plug?
It's been created. That's correct. It's been created, and it's up there in the podcast world of Spotify and Apple and Google and everything else. And it's called Patient First Conversations. It's all about patient care and patient journey, about how it should be. And we've tried to give a perspective on plastic surgery, cosmetic surgery, and the patient journey, and basically looking at what my approach is and how we approach problems as registered specialist plastic surgeons.
So it's all of different patients. It's not just lipedema. It's different patients that you see.
Yeah, it's about 10 episodes. There's wide variety of major topics being discussed, and we didn't discuss clinical cases in great detail. It's more about the philosophy of patient care and safety of patients and the journey of patients and information, communications, accuracy, and all those things that make the journey actually relevant to a patient. Yes, we talk about a few conditions and my experience with certain conditions, but nevertheless, it's kind of maybe the next episodes may be focusing a bit more on detail of the conditions.
Oh, I love that. I'm looking forward to reading it, listening to it, reading it. So with that in mind, is there anything exciting that's happening in the lipedema community that you can share with us?
Look, I think the scientific literature is always kind of quote unquote bubbling with new things that keep coming. And it's only recently came across a couple of scientific papers published in the Plastic Surgery Journal when they looked at the reasons why the fat growth in an abnormal fashion gets triggered by lymphatic stasis. So leading more credibility to the theory that lymphatic dysfunction is the trigger that starts the fat deposition cascade. So these are kind of molecular mechanisms that tell you that, okay, fine. And this was looking at lymphedema patients and looking at why the lymphedema stasis of lymphatic fluid can then trigger off fat deposition in lymphedema patients. And the mechanism in lipedema is not so dissimilar. It is probably very similar, but maybe a different scale. So I think there's a lot of lymphatic biology that's been at the forefront of research for a very long time, and lipedema research also focuses a lot on lymphatic biology. And the lipedema community is very familiar with Ramin Shine and Tara in Melbourne, who have been doing a lot of research on lymphatic biology and adipose tissue, which is basically the fat cell and how they talk and how they interact. And I think it's a lifetime of research from their side, which will be the gift that keeps giving for a very long time.
Yes, we have spoken to them, and we can't wait to see what else that they discover. Well, Dr. Somia, we have come to the end of our podcast. Thank you so much for joining us this evening.
Thank you for having me. It's been a pleasure being on this podcast.
Okay, we
Thank
look
you,
forward
Dr.
to talking
Somia.
to
And
you again.
everybody, if you're listening to us, make sure you check out Dr. Somia's podcast, Patients First Conversations.
Thank you, Deanna. Thank you, Shell.
Bye.
Bye-bye. Thank you. Thank you so much.
When we started the Lipoedema podcast, we relied on word of mouth and existing connections.
Our following has happened organically, and we are so honoured by your support.
As we learn more about the world of social media and algorithms, we have a request.
When you are listening to our podcast or watching on YouTube, let us know what you think.
Hit follow or subscribe.
Leave us a comment or write a review.
The more engagement we get, the more our message is shared.
And the greater our reach to those women suffering in silence.
Thank you for listening to the Lipoedema podcast. Lipedema and its symptoms vary from individual to individual. The opinions and advice voiced in this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you, and please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lipoedema podcast. Until our next episode, bye for now.